Thank you very much, and it's really delightful to be here again and speaking to a group of people who are so interested in trying to make a difference to this condition. And I think the amazing thing for me is Professor Hunt said I started off at St George's, where I was, like every other vascular surgeon, obsessed with aneurysms and lower limb bypasses and the like. And my entire practice in the course of 3.5 years has been transformed to the point where I have not seen or operated electively in an arterial patient now for over a year, because of the just unbelievable demand that there has been on seeing patients with post-thrombotic syndrome as soon as we started recognizing how many people out there actually we could provide an option for. And the answer wasn't just go away, wear some stockings, and good luck to you. So the talk today is just about trying to give you some flavor of where we're at, what we've done, and what you can expect from intervention, because there's no doubt that what has struck me the most about this group of patients is that people are desperate for something. They're desperate for an answer that gives them some hope of restoring some function in their leg, and they're desperate for something that will transform them from being told to go away for years and giving an option. And what we're trying to do is provide some balance to that as well, because it's important not to lose sight of the fact that all the options we have at the moment are by no means perfect, and they're not a panacea. And we need to find some balance in how we proceed. There's some people who undeniably do really, really well, and there's some who it doesn't work for at all, and we've got to try and work that all out. And as much as the research into actually defining post-thrombotic syndrome is really important, we need to make headway in understanding how to treat it and how the whole lot hangs together in a big continuum. One of the problems we have, and this has sort of been alluded to already, is in the talk that preceded mine, is that there's really no clarity and definition and understanding of this. So we've got very poor definitions for what it even is. So people call it post-thrombotic syndrome or post-phlebitic syndrome or venous stasis syndrome or chronic venous insufficiency, and all these terms get muddled up in quite a big way, and a lot of them have got completely different etiological reasons as to why they've developed in the first place, and we need to try and unpick this to get to a much better standard definition. We know that acute DVT presents with big swollen legs, and particularly patients who have DVT extending above the groin, that we understand the risk of post-thrombotic syndrome to be higher. And again, we rely entirely on Susan Kahn's data for the large part in understanding any of the epidemiology of this. And from what we've seen in other fields where we've developed clot-busting techniques, be that stroke or coronaries, as soon as these techniques came into being, they were very contentious in the beginning, but over time, the concept of trying to restore a system to normal at the beginning as soon as you can makes a lot of sense. And we started to see some progress in acute DVT and trying to prevent people getting post-thrombotic syndrome in the first place by getting a system back to as normal as possible in the beginning. And this is the sort of things that you get with post-thrombotic syndrome, venous leg ulcers, and skin changes. This is sort of the severe end of the spectrum, but there is progression throughout, and a lot of patients will come with ulcers. And I'd echo the comments again that I've seen a number of patients now with venous leg ulcers where nobody even thought to ask them whether they had a DVT in the past. They haven't even looked for any scarring or clotting in their leg, and we've had a few patients, and again, not everybody, but we've had a few patients who've had ulcers for 10, 15 years that we've healed within a few weeks of stenting them for their disease and sorting out the May-Thurners and the outflow obstruction. So there are definitely a cohort of patients that we can work on here that we can create a big difference to. But one of the problems we face is that it's hugely heterogeneous. So there's a number of scoring systems that have been brought in place to look at, and as a vascular surgeon, I hardly ever used the CAPS classification before. I'm using it a lot more now, but again, it's an unwieldy, complex sort of thing to apply to patients when you see them, and it doesn't allow us to allow for progression or grading. So if you see class 1 or 2, you'd like to see a system where you can proceed up, find an intervention that takes you back down again. But if you go to C class 6 having an ulcer, you can only ever be C5 because that's a healed ulcer. You can never go back down the scale again. So there's a number of things of finessing how we actually classify people, how we quantify what they've got, that allows us to show not only where people are, but to track progression and to track improvement and to track regression of symptoms over time. I use the Volta scale in every single patient we see in the clinic at the moment to try and understand what their post-thrombotic syndrome is at the time. It's a very difficult thing to apply, and one of the troubles with it is there's so many subjective components to it. So even if I do it every single time and I see the same patients every single time, you might get some consistency. But if I give it to 5 or 6 different people in my team to do it, there's a number of questions here that are influenced by not only the person doing it and looking at the skin and saying, oh yeah, you've got 1 on a scale of 3 of venous ectasia. Oh no, that's a little bit worse today, let's make it 2. Or the patient themselves, where if you see somebody on a good day where their leg feels all right, they're not so bad. When you see somebody on their worst day, it's 3s all round for all of those features: heavy, painful, cramping leg. And one of the things here is to try and classify somebody beforehand to treat them. So the trouble we've had with intervening on venous disease is everybody has said if you're treating people who are not C class 4 and not more than 15 on the Volta scale, you shouldn't be intervening on these patients. And I think that foundation is extremely shaky. None of these scales incorporate things like pain properly, or venous claudication, or inability to exercise. And I think what Susan Khan has shown, which was a really interesting bit of information for me when I found it, was that the quality of life data that she has through extensive work on the veins qual, which is probably the better quality of life scale that I'm using at the moment, suggested the quality of life of patients with post-thrombotic syndrome approximates that of people on chemotherapy for cancer. So if we're looking at a group of patients who are as disabled and are it has been as destructive on their quality of life as all of that, why are we not doing more about it? And that's a question for me when I'm one of 10 people in my department who's the only one offering intervention for this in our hospital at the moment from the vascular side. This is as big a problem as aneurysms. We all know that aneurysms have come up to being a procedure that has got a national screening program for it. There's a huge amount of investment and money in it. Every single vascular surgeon will treat an aneurysm. And by and large, this is a disease process in somebody who's 65 or over, whose life expectancy is limited by their comorbid disease anyway to about a 40% mortality within 2 years of intervention. So we're taking a procedure that is much less common, with much less morbidity, and we're investing far more money into it than we are in PTS. And that comes back to not understanding things, and I think the trials that have been proposed are essential for us to actually put meat in the bones of the arguments that we have. But also, I think there's a fundamental problem in medicine where there's a disconnect between things that don't kill you immediately, because everybody gets an immediate negative feedback to that, and there's a disconnect between things that are quality of life destructive. So if I'm a clinician in an A&E and I see somebody with an extensive DVT and I treat them with anticoagulation, give them stockings, I never ever see that patient again. And if they do come back down the line, they don't come back to me, they come back to somebody else with a leg ulcer clinic or a pain clinic or something else. So that connection that gets made in our brains between I've done this, it hasn't worked, I need to do something different, never gets formed in the same way that it does with an aneurysm patient, that if we don't treat their aneurysm at 6 centimeters, they come in a few weeks later with a ruptured aneurysm and die. They're coming back to me, I see them die, that's traumatic, I want to do something to stop it. So some of this process is actually getting into physicians that post-thrombotic syndrome in itself is not innocuous, that DVT is not something that is a benign condition that all you need is stockings and anticoagulation and you'll be fine, and starting to connect those dots between the negative feedback that comes back to clinicians to force them to want to think again about what they're doing and challenge the conceptions that have come. So May-Thurner syndrome or Cocker syndrome is a thing that you'll all hear bandied about. From St. Thomas's, we sort of feel a compulsion to call it Cocker syndrome because he worked in the hospital and described it. But obviously with all these syndromes, you can't really fight the weight of what comes out there in the internet and Twitter sphere about what different conditions are called. So May-Thurner's effectively refers to only one thing, which is the compression. I'll see if my laser pointer works. It doesn't work on these good screens, these nice fancy screens here. But you get, this one does. So it essentially is only this, where you get compression of the left common iliac vein by the right common iliac artery. Now, one of the problems with May-Thurner syndrome is it is probably present in 60% of the population. It does not go on to cause symptoms in the vast majority. So some of the really crazy things that are starting to come out now are you get seen with somebody who's got an asymptomatic May-Thurner syndrome and somebody will tell them you need a stent to stop you getting a blood clot. There's absolutely no evidence for those sort of statements. So one of the dangers we have is as we push forward in things, you also get a whole lot of madness that comes with it. And we've really got to work together to make sure that we are obviously robust in how we evolve these new specialties. You can see that's a photograph from an old operation of somebody with May-Thurner syndrome. This is the vein that is big and distended behind the compression points by the artery. And this, we think, is a factor in patients who have other things going on in causing clot. So it's kind of a perfect storm. You have a May-Thurner syndrome plus antiphospholipid syndrome or lupus or something else and then something else. And the triggering events together cause clot. It's not one thing by itself. Again, where the research is that it's such a heterogeneous mix of stuff. By heterogeneous, we mean that virtually every one of you in the room who's had a clot has got a slightly different story and a slightly different pattern and a different combination and mixture of all these factors that go together. So unpicking it is quite hard work. We look at the combination of May-Thurners as increasing order of severity and difficulty to treat. So if you have a non-occlusive, non-thrombotic, straightforward May-Thurner's lesion, the chances are, if it's causing symptoms, you can have a stent, it's going to work, it's not going to block, and you'll be absolutely fine. What it doesn't do is provide a miracle cure. So if your problem is swelling, for example, 40% of patients will improve, 20% will have some degree of change, 40% will have no improvement at all. So if you're seeing somebody, and I saw somebody in clinic this morning, whose primary problem is swelling, are you going to put a stent in that patient? You need to be very cautious about that because we have no long-term data for this. So something has to last you 60 years of your life. You don't want to just be going in and having a stent put in for swelling, which may or may not cause you problems in the future or might not improve. And all the way up to the acute DVT patients, we get much better results in treating somebody acutely, and down to the chronic patients where you've got what we call occlusive post-thrombotic disease. There's a term that's crept into the literature which is a total occlusion, which is complete rubbish. It's either occluded or it's not occluded, or there's a stenosis. So there's lots of sort of vaguely, I think, Americanisms of total occlusion that come into what we're talking about. So that nobody has a total occlusion. You have an occlusion or you have a narrowed vessel. And what we need to do is we need to try and pick those out. If there's a blockage and there's good inflow into your vein, you can get good results from chronic stenting, but the results are certainly much worse than the top two groups. And that needs to be borne in mind by everybody who's going for treatment. The issue here really is that once you get a blockage, we know that the pressure in the venous system increases. But we have no fundamentally good way of measuring that. So we have no measure of flow in the veins, and flow is absolutely crucial, and we have no measure of pressure or stenosis that is reliable. So we can't do things that we can do on the arterial side, for example, where we can measure a pressure gradient on either side of a narrowing and say, well, this is significant. So we go with arbitrary things like 50%, which is a made-up number. So a lot of what we do is balanced on uninformed anecdote and personal opinion or experience rather than actual hard fact. And that's where we've got to get to as well, is trying to inform this. But there's a lot of a challenge to go on here. And one of the people I'll mention later on who taught me a lot about venous stenting tried to work with the NASA engineers in Florida where he worked to come up with a measure of flow in the venous system. And they just couldn't recreate it because it's such a complex system. It's not, in life we'll emulate a pump and a pipe on a lot of things, which is the arterial system. So you've got that in your house, on your radiator, on your heating. But there is nothing that emulates what the venous system looks like, of multiple different size vessels that are compliant, that can change size, that are controlled by the calf muscle pump, for argument's sake. So it's a very complicated system that we're only starting to understand. So one of the fundamental things about all of this is you have to have a good team behind you. So this is what happens when you have a really good team of people with the right people in place. And this is what happens when you don't. So, I'm very fortunate at St. Thomas's that we've got a fundamentally good selection of people in our team. And I think without having a team of people and without doing this as a group, you get bad results. So we are in an unfortunate position perhaps of getting patients sent to us who've had things tried by people in isolation, and I think that doesn't work well. So all of you have come with a different story. You might have antiphospholipid syndrome, you might have ulcerative colitis, you might have something else, and we need people like Professor Hunt, Karen Breen, Andy Cohen, Vicky MacDonald, the hematologist, Narayan Karunanthi, who is one of my interventional radiology colleagues, and a bunch of other people who bring their collective expertise and experience to bear on these patients to make sure we get good results. And not only that, it means in a team of people, you stop one person being a rogue madman, and that's a danger in this sort of thing. You have to have checks and balances, and that means people with differing opinions being able to talk to each other about it and say, I'm not so sure we should do that today. Maybe we should think about something different, And I think this is absolutely vital, and that's one of the reasons why I moved from St. George's to St. Thomas's, was because of the strength of the team and the legacy that St. Thomas's had of venous disease treatment, which is something that we're really trying to build on. And in addition to that, like all good rugby teams, there's a bunch of backroom staff that go into this as well. So you might have one person who's the face of it, but we have countless people who contribute to trying to make sure this works. And we do these patients a lot. So we're doing a lot of them now. We're getting more familiar with what goes on. We understand the management better. And this is the way you get good results. And in addition to this, one of the things that we're all bad at, and particularly doctors are very bad at this, and surgeons are probably the worst, is actually speaking to people and getting opinions and advice from others who've been there before. So there's no point in going and repeating the errors that others have made in doing this. So I've been very fortunate in people who've been very generous with their time and teaching us how to do things. There's a chap at the top there who's called Peter Neglin, who's from the States, who now has got an honorary contract with us at St. Thomas's and comes out regularly to look at what we're doing. He's done more venous stenting than anybody else in the world at the moment. And all these other people here who've provided input, advice, comments. When we're looking at patients that are difficult, I can pick up the phone and phone somebody and say, listen, we've tried this, it hasn't worked. Do you have any other ideas or any other options? And I think this is essential in getting any decent system. So in venous stenting, how do we get good results? Well, you have to get the stent choice right, and you have to get the technical aspects correct. And we've got a few more options to that. You have to have flow that is good into the stent system, and you have to get the hematological bits correct. And if you get all three of these things right, you're probably going to keep the stents patent. There is a slide, we'll get onto that in a few seconds, but there are 3 new stents that have come onto the market, and these have sort of raised the profile of venous stenting to a large extent. Cook Silvervena, which has come out, which is this stent, and Optimed, which is another company make this stent called Sinus Venous, and Veniti, which is a stent that I was in a fortunate position to be the first person in the world to put into a patient. But these are all new stents that have really changed the options that we have for patients. But again, the stent is not the panacea. It's just a component of treating patients. So you can have a good stent. If all the rest of the things are rubbish, it's not going to work. And the stent alone will not keep the veins open. It's a component of treating people. The point of venous stents is what we've moved to, is that the venous system is completely different from the arteries. And in the past, we used to put in arterial stents, which were just crushed by the extent of the scarring that you get in the veins. So what we have, the concept of DVT was always, if you've got flow in the veins, that's a patent vein that equals success of treatment. Flow or patency of the vein does not equate to restoration of function. And what the problem is with scar tissue is it stops the veins from working. The scar tissue is incredibly strong. So we blow up really high pressure balloons to open this up, and the stents have to be able to resist that force that's coming down on them. And it's not just about expanding outwards, which is one concept of engineering. It's about crush resistance, which has stopped it from being squashed. So a steel rod is very crush resistant, but it's got no flexibility. So you need to have something in the middle between being very crush resistant and very flexible that will allow you to put a stent into the vein. So this is what we mean by compressive forces. So this is a picture of the inguinal ligaments, and the arrows are sitting down. And when you're going like this with your knee and bending your knee, there's a fixed structure, which is the hip, and a fixed structure, which is the ligament that comes across the groin. And those things pinch the stent in between them and crush them. And that's different to the force that comes from the May-Thurners, which is a pounding force from the artery hammering away at the stent. And it's different from the force that is in between these two areas, which is up here, which is a constrictive force that is being applied to the stent. So there's a lot of engineering that's gone into these. And to develop one stent of one size costs about £4.5 million just for the development process of an individual stent. So it's incredibly expensive to get these things to market and to make them work. You can see here, this is the picture of a patient who's we put into a sort of fetal position on the table with their knees. I can't even do it anymore. I'm becoming so old now. My hips are gone. But you can try and push their hips right up into the chest. Fortunately, not very many people spend their life in that sort of position. So it's the maximum stress for the stent. But you see, you've got to have it going right through those bends. And the interesting thing is, this is the groin. So the maximum bend is deep down in the pelvis, and that's where actually the most movement is happening. So there's a lot of things that we have to understand about how technically stents work. These are the sort of pictures you see of somebody with a venogram showing blockage. You've got all these collateral vessels. On this side, you can see a normal vein, and on this side, you can see the contrast is much darker because it's just not clearing out of the veins. So for those of you who've done science, it's all about Poiseuille's law, which is resistance is radius to the power of 4. So if you take a vessel that's supposed to be 16 and you reduce it to 8, you have 256 times more resistance in that system, which is why we have such high pressures building up in the veins when you narrow them down, and collaterals by themselves do not compensate for the pressure. We use IVUS, which is intravascular ultrasound, to see what's going on in the veins, and this has really been a revelation. I think if I didn't use IVUS anymore, I'd feel that I was blind when I was trying to treat patients. It really helps you to see exactly what's going on with the disease. And it also tells us how long we need to stent. So this is surprisingly long. If you're stenting from here, which is the May-Thurners, down to the groin, that's 24 centimeters long, which is 2 or 3 stents in most patients to cover that sort of length of disease. So it's not a simple thing of just putting in a little stent into the May-Thurner syndrome or something like that to open it up. And you can see here, this is a high-pressure balloon. This balloon's made from Kevlar with Teflon, and we blow it up to 20 atmospheres, which is really high. So that's harder than your bicycle tires are pumped up. And you can see that the fibrosis is deforming that balloon. It's stopping it from opening. We have to crack that until the balloon opens up to really be able to put the stents in. So we do all our patients now under general anesthetic because that is hugely painful. And there was a tendency to do that before under local, and if patients start feeling pain, you're obviously going to stop what you're doing. And if you didn't dilate the vessel up enough, you could end up with a patent stent that was working, but the stent was only open to about 6 or 8 millimeters, and that might stay patent, but it's not going to give you any benefit because of the problems of resistance we've spoken about. So there's a lot about what we have to do technically to get it right. You also have to get the right size stent, and this is a IVUS picture again that helps us to measure the size of the vein so we can put the appropriate size stent in place. And you can see one of the benefits, I don't know if these videos won't play, but what you can see on this video, when we pull back on IVUS, what has really been fascinating to me and I think has been instructive for us while we're doing these, is on IVUS you can see clot forming at the time that you're doing it. And you may not see that on venogram because the venogram doesn't necessarily show it. So we've had a few patients, for example, who had Behçet's disease where we had them with an INR of 4, which you would think stopped anybody from forming clot, where we've seen clot forming inside the stent as we're putting these things in place. So all these patients, we've got a lot to learn about how we control all of these things that are going on to get us to have a good result. You can see that video is playing there at the moment. It looks nice and clean as you come down the stent, but just at the top, we saw that gubbin sitting on the side over there, which is up there, which is clot that's formed inside the stent, and you can't see that on venogram alone. I'll go back to one. Some patients are not straightforward. So this is a sort of slightly gruesome picture, but it's useful to know what's going on here because we can't always do keyhole procedures with stents. So this particular patient, everything was completely blocked. You can see here, this is the groin. There's nothing that looks reasonable there with all these big collateral vessels going off. If you don't have a place to put the stent that all the vein will flow into it, so the blood flow comes in, we have to do things called endophlebectomy and fistula. And what this entails is you open up the vein, which is this bit here, you cut out the scar tissue, and then you join the artery up to the vein to allow you to increase the flow through the stent system, which we maintain for about 6 to 8 weeks just to help the stent stay open until we can then reduce the fistula down and close it off. So this is a big operation on the groin. You can see this is a great result at the end. This patient's stent is completely through there, which was a pathway that was previously blocked with good flow through it. And this particular patient, we closed the fistula 8 weeks down the line, and they've had a really good result. But you get groin infections with this, you get seromas that form with this, there's pain associated with the fistula. It's not a small operation. So the last patient I did, we had to do fistulas on both sides and stent him from his groin to about the level of his liver. It took me 7.5 hours to do this operation. So it's not small surgery. So we have to get on with it, right? So whatever results have we got? So just from our service, acute venous disease, really good results. 94% of the stents have stayed patent. The chronic patients have done less well, but the interesting thing is if we look at their Volta scores, we've reduced them from around 15 beforehand to around 5 post-op. So there's a significant benefit in improving post-thrombotic syndrome. It does not cure it. There's very few people who've gone from here down to here. So what you've got to understand is it's about improving symptoms to give you quality of life. It is not taking it all away. There's a bit about upper limb DVT, which is the same process of constriction between clavicle and spine. And this, again, we can get some good results if you look at lysing the clot, busting it open, and stretching them up. And again, you have to remove the rib. I don't think there's a role for stenting in the upper limb because the movement is too high. It just destroys the stent. So we've got to be very cautious about going there. So at the end of the day, we just got to remember this. So we've got to work as a team, and we've got to try and achieve better results for these patients. And that's going to be driven by research, understanding, and identifying and improving our knowledge base such that we get better results for our group of patients. Thank you very much.